everyone. Today we'll talk about resuscitation, how to resuscitate a patient and save lives. So always remember, resuscitate first, then diagnose after, and always follow the same order. Don't jump or don't skip any steps. So step number one, we'll look at the airway. B, so we have the ABC approach. I think everyone knows about this approach. So A is the airway, B is breathing, C is circulation, right? So when we talk about A, which is the airway here, so I want to know if the airway is patent or not. This is number one. And if it's patent, of course, if it's not patent, this patient might need, urgent intubation, right? If this airway is patent, the next question will be, is this patient able to keep this airway patent or not? If this is a trauma patient, they might have airway damage. Um, if this is an anaphylactic patient, they might have collapse of their airway. Is this a neuro patient with GCS below 8? Is this patient a stroke patient and totally altered? If there is brain bleed, if there is any strong acute neuro disorder that can make this patient not able to keep or protect his airway or her airway. So this is the question. And always don't forget about secretion. This is very, very common. We see it all the time in the hospital and intoxicated patients like stroke patients or intracranial hemorrhage, or for any reason they are not able to protect their airway and they might be having problem with the secretions and they might need some suctioning here. So always open their mouth, always look at their airway, always assess the airway part. Don't skip that part. And I think this is a common mistake. A lot of people just jump to circulation, what's the blood pressure, what's the heart rate, what's the oxygen saturation, and a lot of times airway gets missed. The second part we'll talk about, which is the breathing, right? So when we talk about the breathing, I want to know the breathing pattern of the patient. Is this patient breathing normally, or are they having difficulty breathing? They are breathing very fast. They have high respiratory rate. They using all their accessory muscles to be able to compensate and having a lot of work of breathing. How does the patient look clinically? How they are actually breathing, right? Then we have the two types of, the respiratory failure, whether hypercarbia, which you have problem with ventilation, and you can see high CO2 level and respiratory acidosis. And on the other side, the hypoxia part. Always remember the hypercarbic patient will be somnolent, will be sleepy, and the only way to diagnose the hypercarbia is to get a VBG to assess hypercarbia, right? This is the number one. Number two, hypoxia. Hypoxic patients usually agitated. They can be altered in different ways, but usually hypercarbia make the patient sleepy, but hypoxia make the patient more agitated, right? For the most part, you just need pulse ox to measure the SpO2, right? In some cases, you might need to do an ABG to look at the oxygen in the ABG, but those are very specific scenarios we can talk about in another lecture. But just know SpO2 is a good marker for oxygen. But again, for the CO2, you need a VBG. And if the patient is having a lot of work of breathing, respiratory rate high, they are as acidotic, they having respiratory acidosis, the only way to ventilate will be a BiPAP, right? So these patients need to be started on BiPAP. And if they having bronchospasm, that's very important to listen to their lungs. Don't just rely on numbers. Don't just rely on oxygen and CO2 level. Always, always remember to listen to the lungs. If the patient is wheezy and they having a lot of air trapping, they having a lot of hard time getting all this oxygen out and ventilate. If they are having bronchospasm, for example, and we see this very often in the hospital with COPD exacerbations or asthma exacerbation, So always remember those patients always will need bronchodilators and they will need steroids as well. So this is the hypercarpia. VBG, BiPAP if needed, and treat the bronchospasm if it's present. Then the hypoxia part again, we'll do the SpO2. In the hypoxia, we always try to correct before we diagnose. If you are seeing a patient with SpO2 88 or 85 or even 80, don't think about chest X-ray, doing all the CT scan, CTA. No, this is not the time for this. Always try to correct the hypoxia, then you can diagnose. I'll talk a little bit about the correction, but just briefly for the diagnosis. Hypoxia usually um, um, can present in upper airway disease and lower airway disease. So remember, the upper airway disease, usually the chest X-ray we do all the time, is not the best imaging for upper airway. So always have the upper airway in your mind, and very common scenario for the upper airway. Sometimes they have like difficulty with the secretions or keeping their upper airway open. Um, so always have this in mind. Then for the lower airway, usually we do a chest X-ray. You can do it at the bedside. It's fast. And pretty much you can diagnose or have an idea about a lot of different disorders from just the chest X-ray. And usually when I see a patient that's hypoxic, usually the three different lines of treatment that you can give: steroids, antibiotics, diuresis. So you're gonna get the chest X-ray if they have history of autoimmune disease, radiation, um, any occupational disease. They might have interstitial lung disease. In that case, they will need steroids. If you are seeing consolidation or any signs of clinical pneumonia or clinical infection, then start antibiotics. If these patients have vascular congestion or pleural effusion, they have pulmonary edema, they have decompensated heart failure, they might need diuresis. So when I always see a hypoxic patient, I have those three things in my mind: steroids, antibiotics, diuresis. Which one the patient needs? Then, when we come to the part of correction of hypoxia, there are three different factors. I know it can be confusing to a lot of new residents, interns, and medical students, but actually it's pretty simple once you understand it. To correct oxygen, you have three different factors. Number one is the flow. The flow is just how many liters of air or oxygen you are giving to the patient. Are you giving the patient 1 liter? Are you giving the patient 10 liters? Are you giving the patient 6 liters, etc.? So the flow, right? How much air or oxygen you are giving to the patient. Then the second part is FiO2. When you give someone oxygen, it's not 100% oxygen. And here come the FiO2. How much of this I'm giving the patient 1 liter? How much is actually oxygen in this 1 liter? Is it 20%? Is it 40%? Is it 60% oxygen, etc.? And the PEEP is just a pressure. So sometimes in cases of pulmonary edema or if the patient has ARDS, you need some pressure to push this oxygen in, because if you have a lung that's filled with pus or filled with water or fibrotic or some kind of resistance to the flow, so sometimes you need to give some pressure to push all this oxygen all the way down, right? So the three factors for the oxygen um, delivery devices, it will differ in the flow, the FiO2, and PEEP. And just this is an overview about the different devices to correct hypoxia. We can have a different or separate lecture about it if you guys are interested. But to correct hypoxia, we have an invasive way and non-invasive way. The invasive way, the mechanical ventilation, you put endotracheal tube and you start the mechanical ventilation, right? We try to avoid this most of the time because just the process can induce hypoxia, can produce hypotension. So this is not the best thing to do. The best thing is try to avoid intubation. This is just the last resort. If everything is failed, if the patient is not able to protect their airway, if they have like severe trauma, if you tried everything to correct the hypoxia or hypercarbia and still they are very sick and they might arrest or whatever, this is when you start thinking about mechanical ventilation, right? For on the other side, the non-invasive part, we have two different systems, low flow system and a high flow system. And they're just from the name, low flow, we talked about the flow, the FiO2, the PEEP. So we have on the low flow system, the nasal cannula. The nasal cannula can deliver up to 6 liters of oxygen with FiO2 up to 40. So this is the maximum, this is the limit for the nasal cannula. On the other side, we have the high flow system. And the high flow system, it can be with pressure and without pressure. Without pressure, we have the non-rebreather and we have the OptiFlow. Those are the common ones. There are different, mask, face mask, Venturi mask. There's different systems, but this is the most common that most hospitals use. So we have the non-rebreather mask and the OptiFlow. I put it both without PEEP or without pressure, but some people can debate if OptiFlow can give some pressure, like 5 millimeter mercury. It's very small to low pressure that the OptiFlow can give. On the other side, the high flow PEEP options or pressure options, you have either one direction, which is the CPAP, or bidirection, which is the BiPAP. We can talk about the differences and how to set them up, and that can be a lecture for another time. But usually you need the pressure if you're having pulmonary edema, if you're having severe fibrosis, if you're having ARDS. If it's mixed hypoxia and hypercarbia or just hypercarbia, so if someone's CO2 is high, you cannot give them non-rebreather or OptiFlow or nasal cannula. Those options are just for oxygen. But if they are having mixed respiratory failure with hypercarbia or they are hypercarbic, you need to give them BiPAP, right? Then sometimes if start the patient on low flow, start the patient on non-rebreather OptiFlow, you are getting maxed up on the OptiFlow 70% FiO2 or 80%, and you cannot maximize that. Sometimes if it's refractory, you'll end up using the CPAP or BiPAP. So we talked about the airway, we talked about the breathing and how to correct hypoxia and hypercarbia. The third part is circulation. So when we talk about circulation, we talk mainly about perfusion. So we have the heart, and the heart, we have the vessels coming out of the heart to perfuse the organs. So how to assess circulation? First, you need to make sure the patient is having pulse, right? This is the first thing. Second thing, the rhythm. If the patient rhythm, heart rhythm is normal sinus rhythm, is it bradycardia? Is it tachycardia like VFib or sorry, VTAC or atrial flutter or atrial fibrillation? All these different kind of like funky rhythms, right? Then you look at the blood pressure. If the patient blood pressure is not just systolic and diastolic, what is the actual map of the patient? Because map above 65, the most likely enough for perfusion. And the blood pressure again is just a number. Just don't look at the blood pressure at just one point. Always see the trend. For example, if someone having, very resistant hypertension, their blood pressure all the time 170 over 100 or 170 over 80, and you go there and you see their blood pressure is 90 over 50, that's very concerning because there is large drop in the blood pressure versus someone else who has like neurogenic like orthostatic blood pressure issues, or they are running low as a blood pressure and they are on different medications, and I see their blood pressure is 90 over 50, but it's been 90 over 50 for days, and this is their normal. In that case, I'm not very concerned. So it's not just the blood pressure number, it's also about the trend. How was the blood pressure earlier, if you have this information, if you're following the patient, and how is the blood pressure now. So we have the heart, we have the blood vessels going to the organs. I really like when I try to assess perfusion, I usually look for altered mental status and urinary output. So usually the first two organs that get affected by the low perfusion will be the brain and the kidney. The kidney urine output can decrease. So you can look if they're making urine the last hour, last 2 hours. If they're making urine below zero point 0.5 millimeter or cc per kilogram per hour, that's oliguria that can indicate some perfusion problem. Or if the patient having some altered mental status, they were fine, they were talking, they were laughing, then suddenly they became confused, they don't know their name, they don't know where they are. And also altered mental status always compare. So we compare with the patient alert and awake, then became unresponsive, or they are being unresponsive because they have stroke for a week now, and that's their baseline, right? So we assess perfusion. And then when I think about the perfusion that's going to the organ, the actual blood, you need two things: volume, you need actual volume and actual blood and serum inside the vessels, and you need tone, which is the vasoconstriction to perfuse these organs, right? Volume, if someone having low perfusion or low blood pressure, always start with IV fluid. So IV fluid is number one. IV fluid before vasopressors, before norepinephrine, before anything, IV fluid. And always before giving IV fluid, you can just very fastly assess the volume status of the patient. You can assess the volume status clinically at the bedside, or even POCUS if you have access to POCUS. And remember that not any patient with a diagnosis with CHF, you cannot give them fluid. This is actually very wrong. You can give fluids to patients with heart failure. The question here is the heart failure decompensated? Are they volume overloaded or not? We see it all of the time. People with heart failure, ejection fraction, let's say 30 or 35. But actually, when you look at them, they are not volume overloaded, they are compensated. So if they're having compensated heart failure, in that case, you have to give them IV fluid. Sometimes it's not just IV fluid. If someone having bleed, you can give, blood products, whether FFP, platelets, RBCs, whatever. So fluid is not just the IV fluid or volume, I mean, it's not just IV fluid. Sometimes you need to give blood products. And if you are thinking this patient is septic, they will need antibiotic in the first hour as well. So we talked about the perfusion, we need the heart, and we need the blood vessel to have tone and volume. We talked about the volume, the tone. The tone, you need the vasoconstriction to perfuse these organs, and vasoconstriction, usually we use as a first line vasopressor is norepinephrine, and which is like alpha 1 agonist to cause vasoconstriction. So to increase perfusion, so we'll assess perfusion if the patient is perfusing or not. If they're borderline or not perfusing, we need to assess two things or address two things: volume and tone. Volume always first. So we're gonna give IV fluid first before anything, unless this patient is volume overloaded, maybe they are in cardiogenic shock, and in that case, we'll start vasopressor right away, right? Um, and then the last part about the circulation, I usually like to know their IV access. Do they have IV access? Because those patients, you might give them antibiotic, you will need to give them fluid, you might need to give them blood, you might need to give them norepinephrine. They will need a lot of labs. So those patients, you need to have really good IV access on them. Usually, I like to have at least go to wide IV access, or if you can get like central line or midline or pick or some kind of like bigger accent, that's even better. And emergency situations, you can use IO. Again, this is just a brief summary about resuscitation between airway, breathing, and circulation. If you have any questions, please let me know. Thank you.